Most people never think about this. You roll over out of pure habit, the same way you have for years, choosing whichever shoulder feels softer or whichever hip takes the weight more easily. Comfort decides. Anatomy stays invisible, but gravity sees everything. It pulls on the acid sitting in your stomach, on the blood returning to your heart, on the lymph clearing your tissues, and on the cerebrospinal fluid washing waste out of your brain. Direction is not optional. Direction is everything. And your body was never built symmetrically on the inside. Your heart sits left of center. Your stomach curves left, its greater curvature forming a natural reservoir. Your aorta runs left of the spine. Your inferior vena cava, the massive vein that returns blood from the entire lower body, travels along the right side of the vertebral column. The thoracic duct, the largest lymphatic vessel in the human body, empties exclusively into the left subclavian vein. None of this is random. Embryology arranged every major organ and vessel off-center for a reason. That asymmetry creates a preferred gravitational orientation the moment you become horizontal and unconscious. When you choose a sleeping side based only on comfort, you are choosing a gravitational vector that either aligns with those internal asymmetries or works against them for 8 continuous hours. The consequences begin with the organ that will punish you first if the orientation is wrong. Nighttime reflux is not primarily a chemistry problem, it is a pure gravitational problem. Your stomach is not a neat, symmetrical sac, it is a J-shaped organ. The esophageal inlet sits at the top, the pyloric outlet sits down and to the right. The greater curvature swings left. The fundus, that dome-shaped upper chamber, sits above and to the left of the junction and acts as a gas reservoir, collecting the air you swallow during meals. Lie on your left side, and the greater curvature hangs downward under gravity. Acid, partially digested food, and digestive enzymes pool low in the dependent curve, well below the level of the esophageal junction. Gas stays above liquid, exactly the way a bottle held upright keeps air at the top. Emptying continues with gravity assisting the flow. The lower esophageal sphincter faces almost no hydrostatic challenge. Roll onto your right side and the entire geometry inverts. Greater curvature faces upward. Gastric contents flood directly against the gastroesophageal junction, the exact point the sphincter is trying to keep sealed. The fundus now sits below the inlet and pushes gas and acid upward toward the sphincter. That sphincter must suddenly resist both the weight of liquid pressing against it and the gas pressure coming from below. Same stomach, same acid, same sphincter, completely different gravitational vector, completely different outcome. Think about what this means for the person who finished dinner 2 or 3 hours before bed. The stomach still holds acid and partially digested food. On the right side, gravity pulls that mixture straight against the junction. On the left side, gravity pulls it away. The difference is not subtle. Corey and colleagues measured it directly using ambulatory pH monitoring and published the results in the American Journal of Gastroenterology. Right-side sleeping produced significantly more reflux episodes. Acid exposure time in the distal esophagus was roughly 50% higher on the right than on the left. No medication was changed, no diet was altered, no surgery was performed. The only variable was which side of the body faced the mattress. The difference was pure physics. Now look at the sphincter itself. It was never designed as a simple ring of muscle. It is a high-pressure zone 3 to 4 centimeters long, maintained by tonic contraction of smooth muscle in the distal esophagus and reinforced by the crural diaphragm, the muscular sling through which the esophagus passes. Resting pressure sits 15 to 30 millimeters of mercury above intragastric pressure. That pressure differential is what prevents acid from traveling backward into the esophagus. The sphincter evolved to resist upward pressure while gravity pulled gastric contents downward in an upright body. Every time you stand, gravity assists the seal. In right lateral and supine positions, that geometry collapses. Contents sit at or above the level of the sphincter. The pressure differential shrinks or reverses. Transient relaxations that occur normally during sleep as part of the digestive cycle now open into a flooded junction. Acid escapes. On the left side, the contents sit safely below. The sphincter opens and closes into a dry junction. Nothing is waiting at the door. For anyone whose sphincter is only marginally competent, whose acid production is normal, or whose medication is controlling chemistry but not physics, the difference between waking at 2 in the morning with burning in the chest and sleeping straight through can be nothing more than which side of the body is down. If you still experience the 2 a.m. burn, the bitter taste on waking, the chronic cough that no medication fully resolves, or the morning hoarseness that never seems to leave, the acid itself is not the core problem. The physics is. Gravity is shoving contents toward a sphincter built to hold against downward force, not lateral or upward force. Left side sleeping restores the pressure geometry the sphincter was engineered to operate under. Proton pump inhibitors reduce the concentration of acid. They do not change where the fluid pools. Less acidic fluid pressing against the junction for 8 hours still irritates tissue, still triggers the cough reflex, and still produces the microaspiration that leaves so many patients hoarse every morning. Chemistry and vector are complementary. In the Cori data, the position change alone cut acid exposure by half, with zero change in medication. If you are already medicated and still symptomatic, the chemistry may be controlled while gravity continues working against you. The real question is not whether the medication is strong enough. The real question is which side of the body the treated acid is pooling against for 8 hours every night. Gastric anatomy is only the first asymmetry that sleep position loads. Your cardiovascular system carries an equivalent problem on the opposite side of the spine. The inferior vena cava runs along the right of the vertebral column. When you lie on your right side, body weight compresses the IVC against the bone. Blood returning from the legs, the kidneys, and the liver must squeeze through a partially narrowed vessel, exactly like stepping on a garden hose. Flow slows. The obstruction is not complete, but it is real. When you lie on your left side, the abdominal contents fall away from the vein. The IVC is unloaded. Venous return improves. More blood reaches the right atrium with every cardiac cycle. The heart receives fuller preload and pumps more efficiently against lower resistance. Same pump, same demand, different supply. You will not consciously feel the compression. The cardiovascular system registers it through the baroreceptor reflex. When stroke volume drops, heart rate rises to compensate. Pregnancy studies show the effect dramatically because the enlarged uterus makes IVC compression severe enough to cause measurable maternal hypotension in the supine position. The same physics operates in every non-pregnant adult, only milder. The compression is smaller, but it is present, measurable, and continuous for 8 hours every night. Across years and decades, that adds up to a cumulative hemodynamic load the heart never needed to carry. A heart that receives full preload all night operates at a lower rate, with better stroke volume, and consumes less oxygen for the same cardiac output. A heart working against partial IVC compression operates at a higher rate with reduced efficiency. The difference on any single night is clinically insignificant. Accumulated across a lifetime of nights, it is workload your heart performed that it did not have to. Then comes the system almost no one outside of anatomy classes ever discusses, the system that depends on gravity more than any other. Approximately 75% of your body's lymphatic drainage converges on a single point on the left side of the neck, the junction of the left internal jugular vein and the left subclavian vein. The thoracic duct, the largest lymphatic vessel in the body, collects lymph from the entire lower body and the left upper body and empties there. 1 point, left side. 75% of the network. Lymphatic vessels have thin walls and operate at very low pressure. Unlike the cardiovascular system, there is no central pump. Movement of skeletal muscle, pressure changes from breathing, and gravity do all the work. During sleep, when muscle activity drops and breathing becomes shallow and regular, gravity becomes the dominant driver of lymph flow. The direction gravity pulls determines whether lymph moves toward the drainage point or away from it. Left side sleeping places the thoracic duct's terminus at a lower gravitational potential relative to much of the network it serves. Flow from the right side of the body and the lower limbs is facilitated. Right side sleeping lifts that drainage point higher. Lymph must travel uphill through thin-walled, low-pressure vessels with no pump to drive it. Morning puffiness in the hands, swollen ankles, or a general sense of fluid retention that resolves within an hour of standing is often interstitial fluid the lymphatic system failed to clear overnight. Once you stand, gravity finally points the right way, and the backlog drains. That morning correction is gravitational, not magical. The lymphatic system's role in immune surveillance makes the overnight efficiency even more important. It filters pathogens through lymph nodes, presents antigens to lymphocytes, and clears cellular debris from tissues. Overnight drainage efficiency therefore affects immune function during the exact hours when the body performs its most intensive repair and immune maintenance. The position that optimizes drainage for 75% of the network is left lateral. The position that impedes it is right lateral. The difference is gravitational, 9.8 meters per second squared, acting on fluid in thin-walled tubes for 8 hours. Your immune system does not know which side you are sleeping on, but the fluid that feeds it, the lymph carrying antigens to nodes, immune cells to infection sites, and debris away from healing tissue, flows faster or slower, depending on whether gravity assists or resists the primary drainage pathway. The side you choose determines the throughput of the system that maintains immune surveillance while you are unconscious. That asymmetry, 75% of lymphatic drainage converging at one left-sided point with gravity as the primary overnight driver, is the fact that becomes impossible to set aside once you see it. Every night spent on the right side places gravity in mild but consistent opposition to a drainage system that clears tissues and supports immune function. Not dramatically, not dangerously, but consistently, for hours, in the wrong direction. The lymphatic system was not designed with sleep position in mind, yet sleep position determines whether gravity assists or resists its main pathway. And then there is the brain's waste clearance system. What was discovered in 2012 changed the understanding of what sleep actually does. The glymphatic pathway, cerebrospinal fluid flowing along perivascular channels surrounding arteries, collecting metabolic waste including amyloid beta and tau protein, then draining along perivenous channels, was mapped by Mike and Nedergaard's group at the University of Rochester. The system operates primarily during sleep, when the interstitial space in the brain expands by approximately 60%, dramatically reducing resistance to fluid flow. During waking hours, the glymphatic system runs at only a fraction of its sleeping capacity. Your brain waits for sleep to clear the metabolic waste accumulated over 16 hours of neural activity. The efficiency of that clearance is a fluid dynamics problem. Fluid flows faster through tubes when gravity assists rather than resists the flow direction. Sleep position sets that angle. For anyone over 65, the implications are direct. Amyloid beta, the protein whose accumulation is associated with Alzheimer's disease, is cleared from the brain primarily during sleep through this pathway. The rate of clearance is influenced by the orientation of the drainage pathways relative to gravity. Xie and colleagues published in the Journal of Neuroscience in 2015 that glymphatic transport in rodents was most efficient in the lateral sleeping position compared with supine or prone. Lateral position produced the fastest clearance of amyloid beta tracer from the brain interstitium. Those data established lateral over supine or prone. They did not distinguish left from right. The anatomical argument for left specifically rests on jugular vein asymmetry. In most people, the right internal jugular is dominant, carrying roughly 60 to 70% of cerebral venous drainage. In left lateral position, that dominant vein sits uppermost, optimizing the gravitational drainage angle into the superior vena cava. The logic is anatomically sound. Direct human measurement of left versus right glymphatic clearance rates has not yet been performed. Research remains largely in rodents. The mechanism is plausible. The rodent data supports lateral positioning, and the anatomical case for left, specifically, is consistent with known jugular asymmetry, but it remains an extrapolation rather than a confirmed human finding. The heart itself has a positional preference because it is not centered in the chest. It sits in the left hemithorax, suspended within the pericardium, apex pointing toward the left anterolateral chest wall. In left lateral sleeping, the heart rests against the chest wall, with gravity assisting its natural position. The apex settles toward the chest wall. The valves maintain their design geometry. The great vessels keep their normal angles. In right lateral sleeping, the heart hangs from its great vessel attachments, the aorta, pulmonary arteries, and vena cavae, and swings rightward within the pericardium. This produces a slight mediastinal shift that can alter the geometry of the tricuspid and mitral valves. For most healthy adults, the shift is clinically insignificant. The heart accommodates positional changes without measurable dysfunction. For adults with enlarged hearts, pericardial effusion, or existing valvular disease, conditions whose prevalence rises substantially after 65, the gravitational loading of the heart in right lateral position may produce measurable changes in cardiac output and valve competency. If you have noticed that sleeping on your right side produces palpitations, a sense of irregular beating, or nocturnal breathlessness that does not occur on the left, a gravitational shift in cardiac geometry is a plausible mechanical explanation. The mechanism is anatomically coherent. Gravity does alter annular geometry, and the effect would be larger in hearts with age-related dilation. Direct measurement of positional valve competency during sleep has not been performed. The connection is mechanistically sound, but not yet a confirmed clinical finding. Now consider what the convergence means. Every system described here, gastric reflux, inferior vena cava compression, lymphatic drainage, glymphatic waste clearance, and cardiac pericardial geometry, carries its own anatomy, its own fluid dynamics, and its own evidence base. All of them favor left lateral sleep position through one shared mechanism, gravity acting on fluid and tissue inside asymmetrically arranged structures. The convergence is not design. It is the inevitable consequence of a body whose internal organs are off-center, lying horizontal in a gravitational field that never turns off. No physician has ever routinely asked you which side you sleep on. No standard health assessment treats sleep position as a measured variable. No prescription for reflux medication arrives with a note about gravitational vector. Yet the side you choose every night, a decision made unconsciously, maintained unconsciously, and never told that it matters, determines the gravitational vector applied to every one of these systems for 8 hours. The reflux that wakes you, the morning puffiness that resolves by noon, the cardiac efficiency during the hours your body repairs itself, the rate at which your brain clears the metabolic waste of the day, all of these are influenced by which side of the body faces the mattress. The variable has been present every night of your life. It was never measured because almost no one thought to ask. No single system makes the entire case alone. The reflux data is the strongest. Corey's 50% reduction in acid exposure was measured directly in humans with ambulatory pH monitoring. If you experience nighttime reflux, the left side evidence is clinical grade. The IVC compression is established physics, confirmed in pregnancy studies, and applicable to every body. The magnitude in non-pregnant adults is smaller, but the mechanism is identical. The lymphatic drainage is anatomically certain. The thoracic duct terminus is on the left. Gravity assists drainage in left lateral position, even though no study has yet measured overnight lymphatic flow rates by sleep position in humans. The direction is certain. The magnitude remains unmeasured. The glymphatic data is the most preliminary, rodent evidence supporting lateral over supine, with anatomical reasoning favoring left, but no direct human measurement of left versus right. The cardiac geometry is mechanistically plausible, but unmeasured during sleep. Multiple systems at multiple levels of evidence, all pointing in one direction. The direction is left. The person who sleeps on their right side tonight is not in immediate danger. They are not making an error that will produce sudden consequences. They are simply choosing a gravitational orientation that works mildly against these systems for 8 hours, night after night. The person who sleeps on their left side is choosing the orientation that works with them. The difference on any single night is marginal. The difference across years of nights, consistently in one direction or the other, is a cumulative variable that no longitudinal study has quantified, but that the physics makes directional. Knowing the physics changes nothing if the body cannot adopt the position. Habitual sleep posture is one of the most deeply consolidated motor patterns in the human nervous system. You have maintained a preferred position for decades. The motor programs that keep you there during sleep operate below conscious awareness. You roll, adjust, and resettle without waking, guided by a pattern your nervous system locked in years ago. Transitioning to left-side sleeping requires working with that unconscious system rather than fighting it. Studies of sleep position retraining typically use physical barriers, a body pillow placed firmly behind the back, or a mild incline that favors the target side, that the sleeping brain encounters and respects without fully waking. These barriers are not permanent. They are training aids. They give the unconscious motor system a boundary that prevents the habitual roll to the non-target side. The first nights feel unfamiliar. Your body is accustomed to a different pressure distribution, different shoulder loading, and different hip alignment. That unfamiliarity is not evidence that the position is wrong. It is the motor system meeting a configuration it has not maintained overnight in decades. For anyone over 65 dealing with left shoulder pain or left hip discomfort, common concerns that make left side sleeping initially uncomfortable practical solutions exist. A pillow placed between the knees reduces hip abductor strain and keeps the pelvis aligned. Support under the rib cage reduces compression on the shoulder. The skeletal discomfort is a joint loading problem that can be solved with strategic support rather than abandoning the position. The goal is not to endure pain. The goal is to distribute load so the skeletal system accepts the new position as comfortably as it accepted the old one for decades. Adaptation periods of 2 to 4 weeks are consistently reported. After that, the new position begins to feel natural. The unconscious motor system incorporates it. The props become optional. The body has learned a new default. That convergence, every fluid system in the body that depends on asymmetric tubes, each with independent anatomy and independent evidence, all aligning with left lateral positioning through a single gravitational mechanism, is what makes the research irreversible once you truly see it. The side you sleep on is not a preference. It is a physics variable that determines the direction of gravitational force on every major fluid pathway for 1/3 of your life. Your body sleeps for approximately 1/3 of its existence. During those hours, gravity does not stop. It acts continuously on gastric contents, on venous return, on lymphatic flow, on cerebrospinal fluid, and on the heart itself, for 8 hours, in whichever direction you are oriented. Left side sleeping aligns that force with the internal asymmetries of a body whose organs are not symmetrical and whose fluid systems depend on direction. Tonight you will still choose a side. You will do it unconsciously, out of habit, based on comfort rather than anatomy. But now you know what that choice actually determines. Left lateral sleeping is not a wellness trend. It is not a social media tip. It is the gravitational orientation that matches the internal architecture of the body you actually have. The physics operates whether you know about it or not. Now you know. The direction matters. Choose the side that works with your body instead of against it.